Tēnā koutou katoa e te whānau whānui, ngā mihi kia koutou, ko Mary Simpson of Waikato, and welcome to this session. We were going to talk, present papers from the session, the role of culture and community resilience, care and intergenerational solidarity. So if you've arrived for that session, we'll encourage you to stay for the one we're actually going to do. There was an issue with the fact that I had withdrawn the paper for that panel, and then there were so few videos that we decided it was a good idea to move to a different paper which I was presenting, a different panel that I was presenting. So this is about reconfiguring the invisibility of care, caregivers' perspectives, and it's a theme session panel with Kirsty McCullum, LaTonya Trotter and Jared Goggin. But we're not going to play the whole 48 minutes for you. We thought that you can do that for yourselves. But for the moment, I just want to introduce the whole panel, and then we'll hear from Jared, LaTonya, and a small presentation from me, and then we'll open up for discussion. So the panel is concerned with paid caregivers and unpaid caregivers. So while the rest of the world shut down in March 2020, paid caregivers left home to go to work. As newly minted essential workers, their jobs became highly visible. Over the same period, many kin caregivers found themselves unable to access external support. They were confined to small bubbles. I don't know if you had bubbles where you live, but in Aotearoa, New Zealand, we had bubbles of family members. These front stage, backstage performances of care show that caring is neither inherently visible nor invisible. Nonetheless, informal care and much paid care work tends towards invisibility because it occurs in private spaces, it's socially marginalised and or poorly remunerated compared to other types of work. Other theoretical accounts of invisible work argue that those who do the work are treated as non-persons and thus disappear from view. They disappear from view to do the work, and the work that they do is ignored, devalued, or relegated to an inferior plane. Although much empirical research confirms those invisibility mechanisms, we still know little about how care workers, through their front stage, backstage communication, accept or contest invisibility. So this panel examines how caregivers of varying stances, unpaid, paid, professional, across different care contexts, home-based, residential care for older people, and community care for persons with disabilities, as well as hospital care, and cultural settings describe invisible work and being an invisible worker, and how they react to and resist invisibility. The panel involves 5 micro presentations, which we'll hear the first one first, and then which are embedded within a broader discussion. So if you want to hear the whole panel discussion, you can access that. But first, I want to listen to let's listen to Jared Goggin. Jared is going to talk about invisibilities of disability care, communication technology, and social futures. Over to Breeze.
I don't have the access.
Over to Mohan.
Log me out. Sorry.
This is when you talk amongst yourselves.
Or look at your phone.
Yeah, or look at your phone, or check your email, or check you're in the right panel.
So I'm clicking on the link you sent, Mary.
Yes, it should just open up. And it should come up with a red if you press it. Okay, yes, see the red bit, if you just click.
Okay, I will just first.
Jennifer Smith-Merry in the Centre for Disability Research and Policy, University of Sydney. So we're talking about invisibilities in disability care, communication technology and social futures. Delighted to be part of this terrific panel. So in particular, I suppose what we're adding is the disability perspectives on care. And starting from the standpoint that, or the sit point, that disability has often been, particularly in the last couple of decades, been reconfigured globally. And its relationships with notions of care, with practices have been transformed. And that disability and all its intersectionalities and diversities offers rich and significant perspectives on care. Not least because in disability studies, as in feminist ethics and philosophy, there's a lot of emphasis put on the central concept of interdependence, the really constitutive relationships between ourselves and others and collectives and our environments and species. So how we imagine and enact care and its relations, we'd say, is very much bound up with what Mick Meyer calls, quote, negotiating the social order of disability. And actually that feeds into larger understandings of society, so the norm and the normality of social life. So we combine this with recent thinking on disability and communication and the economy of invisibilities. Specifically here, the work of our doctoral student, Stephanie Mantia, who's doing a terrific study of invisible disabilities, obesity, and health communication in platforms like Instagram. So in an article that I co-authored with Stephanie on Australian TV and disabilities, we talk about the certain kinds of disabled bodies strongly associated with and taken to represent people with disabilities, including when disability activists have leveraged the politics of visibility. And that there's used signifiers of disability, in which some are privileged, I suppose, and particularly valued in neoliberal contexts that push for diversity. And we reference here the great work of David Mitchell and Sharon Snyder in their Biopolitics book of 2015. They're talking about inclusionism and particularly able nationalism. And so what Stephanie and I suggest in this article is that the economies of visibility are highly influential in social relations and exclusions and inclusion of disability. So our case study in this paper is reconfiguring the visibilities of disability care in the Australian context. So particularly this hinges on this remarkable and groundbreaking but also problematic initiative at a national level in Australia, the National Disability Insurance Scheme, saw Australians with disability gain the right over a decade, or almost a decade ago, to access the services and support they needed. It's a consumer-driven approach, really aiming to put the consumer in control of the services and supports via individual plans and assessment, involving personalisation, but a complex kind of system of market provision and contestability, and also governance that's itself not hugely visible or legible. So the process of social change, activism, political transformation that saw the emergence of NDIS as a water cooler issue, really, in Australia, featured an emphasis on voices of disabled people, particularly leading the conversation. Our colleague Kate Hill has written about this in relation to listening, that key concept that balances, I suppose, and interweaves with voices and the right to speak is listening and the politics and regimes of listening. But it kicked off in Australia a national conversation around imagining and reenacting of care. We've got a website here that references some information. This Carers Australia information on carers and NDIS and videos about carers and Indigenous people, for instance, carers and NDIS from other groups as well, and the Carer Gateway of the Australian Government website, Carers and NDIS. So, in short, in the Australian disability landscape, carers have been underwriting its transformation, but not really included or fully visible. There, of course, was a shift in the disability politics in the last 10 to 15 years, where interests of carers and organised alliances of carers have driven particular interests in disability transformation. And I think some of those politics have been reconfigured. But I think that in our estimation, there's aspects of care that really need to be unpacked and acknowledged more greatly. So we can see alongside the NDIS, which has in some ways loomed large in the Australian disability landscape and obscured the many other aspects of support and disability caring that go on. There's also the digital economies of caring, the new kind of caring economies that take the form of a range of digital technologies, where the official ones that NDIS and agencies use, or automated decision making as well in this, or actually the use of WhatsApp messaging apps and social media around caring. We've particularly seen this in the COVID pandemic with the use of technologies such as the one we're using here, which can offer new accessibilities as they actually enact new kinds of inclusions and new accessibilities. So overall, we see over the last 10 to 15 years, some aspects of disability care becoming more invisible, others being rendered less invisible. So we can see this in an important report that Jen Smith-Merry and colleagues did in 2018 on people with psychosocial disability and the NDIS, and particularly the aspects of that that focused on carers. So one of the key issues was that around carers and care was the lack of inclusion in assessment and planning, the complexity of the process, and the multiple barriers to carer needs being included in individual plans. And the report called for re-implementation of carer support and education programs, and for individual NDIS plans to consider and redress carer burden, and also culturally aware family inclusive practices. So in this brief presentation then, just let us conclude with some remarks about the invisibilities and self-invisibilities of care, some observations. Caregiving is often invisible, even to people who are doing it. In research, it's often difficult to find carers to talk to, but those who we do talk to in here, these are, I think, particularly the perspectives of Jen and her research teams, do talk to and self-identify and opt into the study and studies, then they are strong advocates for the people they care for. But there's a cognitive leap and I suppose an effective leap also that needs to be made for people to self-identify as carers, and there's tension in this. Some of this comes out in the resistance to the term carer being used in some context, the confusing language use and preferences around this. Language of informal carers might make informal care invisible in relation to these aspects, but also
Did I cut it off?
different.
It got, I think that's where it got closed off.
Did I cut it off too soon?
Yeah. Do you want me to keep playing? Can I do that?
If you can, I don't know that you can. Oh no, because it finishes there.
Oh, okay.
2660.
All right. So my apologies, everyone. It seems that my editing skills are not that good, especially under pressure. Even when I'm not under pressure. So I just thank you, Gerard. It was interesting hearing that again, having not heard it for some time. But I have to pick up the last points that you were talking about was the actual invisibility of care to carers themselves, and the shifting the shifting ideas of what becomes visible as we talk about care with and by and for people with disabilities, and then what is becoming more visible and what remains invisible in the practice of being participating in planning for ongoing care when you're the carer, and we'll come to that in a moment in some of the work that I've done with our team. But now I want to introduce LaTonya Trotter. She talks about the invisible organisational care work of professional nurse practitioners, and this. So I'll leave it to her to talk. It's a very powerful presentation. And we're handing over to Mohan. Thank you.
going to do my best to get this
And
going.
let's hope my editing skills are
Well,
better.
thank you everyone for viewing our panel, and I look forward to sharing my contribution to it. But before I launch into the substance of the paper, I want to spend a few moments diving into the substance of our collective moment, which is, of course, the pandemic. Now, those of us living in places with access to vaccines are beginning to feel cautiously optimistic, but I want to invite you to go back a few months to when optimism was in short supply. I want you to remember how you felt when you first saw images of nurses in New York City donning trash bags in lieu of PPE. And if you can remember what went through your mind as you read stories of ICU nurses being told to wash and reuse single-use N95 masks. Now, partly what makes these stories so evocative is that they are seemingly born of extremity, a crisis far removed from the normal state of affairs. But I argue that the logics that produced these stories were not caused by the pandemic, but preceded it. And that these logics don't just inspire, but require the sacrificial work of nurses. A sacrifice that is not made on the altar of patient care, but on that of masking and maintaining social inequality. Because the crux of my argument is this. Before, during, and eventually after the pandemic, the roughly 3 million registered nurses working in the US will not only be tasked with performing the visible work of caring for patients, but the invisible work of shoring up a healthcare system crumbling under the weight of social inequality. And it is through attention to that invisible work that we can more clearly see the normalized state of crisis in which our medical system currently functions, and can consider the constraints of nursing work as one thread in a larger project of misrecognition that threatens to obscure and normalize inequality within healthcare and outside of it. Now, I came to this conclusion through empirical attention to a particular kind of nurse, the nurse practitioner. So NPs are registered nurses who have completed additional education to make the kind of diagnostic and treatment decisions that were once done only by physicians. Now, they were a policy solution created to provide primary care to populations underserved by physicians and to be cheaper than the physicians they were replacing. But in order for nursing to make the case that they could be this kind of solution, they had to argue that they were offering something similar or indistinguishable from physicians. So in a sense, the nurse and the nurse practitioner had to become invisible. And importantly, this argument of interchangeability was made not to individual patients, but to organizations that employ NPs and to the state that regulated them and as an insurer reimbursed for their services. So how this orientation to employer and state needs shaped NP work was the question that motivated this paper. So I use ethnographic field methods to explore two comparative cases of organizations in which nurse practitioners performed the majority of medical work. The first was an organization with an expansive mission of comprehensive geriatric care. It provided not just medical care, but supportive care and coordination services, with the hope that this kind of support could delay nursing home placement. And the second site had a much more narrowly defined mission of providing reproductive health services. Its provision of highly politicized care, however, made it a social movement actor as well as a healthcare organization. So what I found was this. At both sites, NP expertise was marked by its organizational expansiveness. So at the geriatric clinic, the NP became the fixer of not only medical concerns, but also social and organizational ones. They were called in to troubleshoot behavioral issues, family disagreements, as well as helping patients navigate the layers of bureaucracy required to provide comprehensive care. And at the reproductive health clinic, the NPs displayed a similar orientation. They helped the front desk manage clinic flow, pitched in when the clinic was down a medical assistant, and they helped patients with non-medical problems having to do with accessing and paying for care. So both of these organizations hired its nurse practitioners for their medical expertise, but in practice, they were used as much more than substitute physicians by both patients and the organization itself. So building on both Arlene Kaplan-Daniels' concept of invisible work and the literature on reproductive labor, I demonstrate the ways in which nursing is engaged in a form of work that isn't just about reproducing workers, but in reproducing social institutions and the regimes of inequality embedded within them. Because the organizational care work that NPs do has a way of drawing our attention away from the fact that many of the problems they address from within the medical encounter are social problems that have gone unaddressed outside of it. And whether the crisis is the fast-moving one of the pandemic or the slow-moving one of state retrenchment, it is often nurses who are pressed into the invisible work of knitting together individual safety nets in lieu of one crafted by the state. This knitting together may be a lifeline for patients, but lifelines are only necessary when one is drowning in a sea of despair, shaped wholly by the disinvestment of the state.
The way in which she knits together the personal and the political, the everyday practice of nurses and caring for the patients, as well as having to address manifestations of social and economic problems that are created elsewhere. It really extends the whole notion of care. So I'll move to my little presentation, and it is little, but I want to preface it. It's because there is a context that's quite important in this. This paper is about whānau caregiver invisibility within a collective constellation of care. And it was born out of a study that Christine Unson and I started in 2018 in Aotearoa, New Zealand. We had identified in our respective work that socialisation of carers, we just don't know how people become carers. We thought that there was something going on, that certain people ended up being carers, but it's not visible to everybody else. And then we joined forces with Kirsty McCullum and Stephanie Fox to look at the whole care as a constellation. And Te Oha Hancock was a research assistant with me, and through her networks, my networks, and the networks of another colleague, we ended up interviewing mostly Māori caregivers, or carers. I prefer to call them carers. And because of the nature of the group, we ended up with a culturally distinct group of participants, and therefore had to really interrogate, well, how we got there, which is who knows who, basically knowing people. And then what do we do with that? So this paper looks at the lived experiences, voices and stories of Māori whānau caregivers of kaumātua, that's older relatives. And this is not easily acknowledged to outsiders, such as me as a Pākehā, or even whānau themselves, as we found out. So we use semi-structured interviews for whānau members caring for kaumātua, and this explores how they experience invisibility in their care role. And the analysis identified several interconnected factors that created and sustained that such invisibility. So the short presentation that you're going to hear now summarises that, and once we get past that, then we'll open up to a discussion. So, Mohan?
Kia ora.
Oh, kia ora. I got it right.
Koutou katoa, e te whānau whānui. That means greetings to everyone who is listening to this presentation. Our research question was, how is invisibility evident within whānau or family collectives of care? The reason this is important is because 1 in 4 New Zealanders will be 65 years or over in 2040. Secondly, unpaid family caregivers are predicted to play an increasingly important role in caring for older adults at home. Also, there's an increase in multi-generational living arrangements, and this is particularly among Māori families and Māori communities which value older relatives. And the other part of this is that of the nearly 500,000 New Zealanders caring for a relative or friend with a disability, Māori whānau caregivers, both men and women, are underrepresented. This is despite the value of such care being approximately $10 billion a year. Whānau care is both culturally normal and stressful, and yet culture-centred experiences of giving care also sustain not only the care of the family, but also the whānau and family relationships. It's important, therefore, to acknowledge that Māori whānau care is a normal part of life, but that demands, duress and invisibility experienced at a systems level need to be made visible. We have three main findings. The first one concerned the value of whānau care, that it was normal. And invisibility in this theme concerned the very normalisation of care. It involved intergenerational giving forward and giving back, and was founded on relationships, strong relationships within the context of aroha, love, and manaakitanga care. The second theme was collective coordination, and this centred around role identification. And what we found was that no matter what role relationship the whānau carers had with the older person, whether it be daughter, moko, grandchild, or cousin, niece, husband, they all identified as carers. And this involved some level of coordination, which by some particular members in the family. So there was a range of direct support, direct care, supported care. However, when things went wrong, when coordination broke down, this was a real challenge. So in terms of theme 2, this centred on the multiple elements of caregiving being invisible to different members of, or being visible and invisible to different members of the caring network. And the third theme was whānau care as visible and visible. Here, outsiders would come and say, "Oh, how are you? You look okay." So this fractured moment that the outsiders or the visiting whānau would see a situation as just in that moment, whereas the caregiver, the primary caregiving collective, may have been under a lot of stress at that time and not coping, which leads to the second part of this, which is after dark, the unseen, those fractured moments when caregiving whānau are doing it alone. And it was very hard. That's our findings for now, and we look forward to having some conversations about it.
Well, we've analysed the data quite a bit more since then, but I'd just like to open it up to Mohan and Debashish to ask questions, or anybody to ask questions, but we'll start with these two.
Well, thank you, Mary.
I'll step back so I can see you both.
Thank you for all three of you for your presentations. I think it's really good. Let me start with a very broad question. Why is it that people and professions that don't really care are so much more visible than people and professions that care? What does it tell us about the structures of the political economy that the world is in?
I keep thinking about Christine's presentation and how there are normalized ways of normalized structures of communication. So you have, I'm going to have to go to someone like a CEO. A CEO, he, she has a picture in the paper or online, and it's very visible. Yeah. They are the go-to people, and I think those kinds of structures have been normalised within society. So when you've got carers, I don't think women are allowed, most of these carers are women are allowed to complain. And also if it's part of the role, you just do it. You do it because it's your mother, it's your patient, it's your a family member. So you're so in the moment. I don't think you've got time to talk about it. I'm not really answering your question, but I think that there's not the recognition of the day-to-day, everyday things that people do. There are much more sexy things that can make the headlines. I do think COVID has changed it. marginally, although the nurses at the moment are fighting for, in New Zealand, are fighting for salary increases, a recognition. But I think that it'll be interesting to see how that plays out.
Right. Before I open it up, I just had one other question. So the three of you have talked about the invisibility of disability and of professional nurses and whānau caregivers. What might be some of the threads that bind all three together?
The first word that comes to mind is commitment. Gerard raised the point that carers are advocates and nurses advocate, and caregivers, whānau caregivers advocate for the people that they care, who they care for. In each case, they privilege someone else.
Right.
So I think that's one of the threads.
Okay.
That's the one that comes to mind first, anyway.
Okay. Thank you for that.
Tonight?
Others?
Kia ora. Loved it. Marianne, loved all three presentations that we had a chance to witness. I go back to something that you used yesterday, the word insurgency, and connecting back to that concept to today and looking at your whānau caregivers, I wonder if there are insurgent ideas from within these narratives that actually offer openings for dismantling this political economy of invisibility.
I think there's the potential for that. But I don't know that I'm going to be someone who can witness that or highlight that. But if I go back to Christine's presentation this morning about how making connections between, for her hapu and iwi wanting to organise the council to take control of that space, I think that there are moves within Māori to make the work of their whānau more visible and needing more recognition and more support. But I can't name those threads. I don't know if it's my position to name. Sorry.
I'll just say I was taken by the final speaker and her description of seeing the nurses. If I may, just really, it was one of those images that, especially, having lived in New York, it kind of struck me, is often the media does depict this image of, we only see people, medical workers, struggling in what we call like third world. And it's interesting, when the pandemic first struck, the places that were really having those issues of burying people in mass graves, we saw those images in the US. And so we saw these first world, in quotations, first world countries struggling. We saw people being put in garbage bags almost. They weren't garbage bags, but basically put in these bags, and cities like New York City couldn't cope with this. And those images were really, I think, almost flipping the script really in many ways on what is developed and what is not in some ways. And I really appreciated, it was sad, of course, it's still dreadful to see those images, but it almost was like everywhere can have the same problem. Every system can really crumble under the right conditions. And so it just really, when I was listening to that, that's one thing that kind of just jumped at me, just from also having family in Brooklyn, having family in Manhattan, in those areas. Like, they were seeing it outside of their windows during their lockdown, I guess. So that's still, it's in my brain, because we still can't go home to the US, and those kinds of things. Just
I think for those images are deeply unsettling. And just to go back to something you said, Mohan, I think that when we are confronted with something different, we are more likely to shift. But at the moment, I think there's still the remnants of chaos is still here, and I don't think the things have been sorted yet. I would like to think they're in the process of being sorted, but that's why I came back to the nurses. Right now, they're about to go on strike in New Zealand for, I don't know, for 28 hours or something. And to think that they're having to do that on the back of what's just gone in the last year, it's what's going on. you know, so. Any further comments, additions?
Kia ora, Mary. Thank you very much for putting up this very interesting panel, and thank you for all presenters. I wanted to ask you regarding your research, because I'm interested in cultural factors and cultural differences, because if we look at Aotearoa New Zealand, we have Pākehā, who are sort of mostly individualistic society, and Maori and Pacifica, who hold to very strong collectivistic values. And coming originally from Russia, I can say that in Russian culture, for adult children or even middle-aged people to care for their parents when they're old and fragile is considered such a norm that it is definitely an invisible care and function that so many people provide without even discussing it as caring, because it goes without saying. So my question is, how do those differences play in Aotearoa New Zealand when we have two different cultural systems of values and different attitude towards older generation in your family and sort of more extended family in the form of whānau?
There are multiple cultural ways. First, that's the first thing. Secondly, yes, because when you okay, I care for my mother and that she lives with us, right? COVID came along, bang, went and got her and brought her home to make sure that she wasn't on her own. I was not alone in that. So there, from a personal point of view, I'm a family caregiver, but I didn't think about it as care any more than, so, you know, your Russian colleagues and families, it was just normal. And that plays out with these Māori whānau caregiver too. It's just normal. It's just what we do. But because of that, then family members end up doing more than just housekeeping or personal cares, and all of a sudden then it's managing someone who's wandering at night. They end up taking on these tasks and care tasks incrementally and increasingly, and then they're worn out. I don't know where I was going with that. There was care as normal, but then around the coordination with the whānau members that we spoke to, there was this implicit organisation around it, that where moko's grandchildren would provide the personal relational thing. They would go and visit, or so that mum could go out and do the shopping or have a break. But there was a direct caregiver or more around the older person. So everybody had a role. And then you had cousins, horizontal cousin relationships this is grandchildren, one would be the main visitor, but he or she would coordinate the other cousins to come in and look. We had originally intended to talk with a range of people, but because of the people I knew and the people the others knew, we ended up with mostly Māori, which I found ironic. I really did. But we wanted to go out and interview people. We'd actually arranged to go down to Southland in the South Island, because we figured there'd be more Pākehā down there. But then COVID came along. So I'm not sure. I would like to. I think about the people I know who are Pākehā and care for older relatives, and it's definitely there. They wouldn't necessarily call it care either, but it might be played out differently. It might be played out, organised differently, but it's still there. So I haven't got the research is the way you find out what everybody knows, and then build on it. So that hopefully we'll get there.
If I may, One of the things I'm wondering is, I almost look at COVID almost as like in the movie Back to the Future. You have one timeline, then COVID struck, and like there's a whole new timeline basically in the world. And what I'm wondering is, we look to the idea of, a carer, is I'm wondering if really like what brings someone, or the characteristics of someone who you're talking about, what leads someone really to this isn't going to be as articulate as I'd like it to be. I haven't had enough caffeine yet. But what I'm wondering though is really, if we look to really what happened with COVID, is I'm wondering it wouldn't be as much a cultural individualism, collectivism, or as much even like Pakeha Maori. I'm wondering if with COVID striking, this could be maybe controversial for some, I'm wondering if maybe it's an evolutionary psychological aspect here, where really some of the research we're doing is we're finding that all of our constructs aren't working the same way anymore because of the contagion effect, which we're really focusing on in some articles we have under review now, is really this issue of COVID's here now. And so basically people who may not have been carers before now have to be, or never knew they had that instinct before, but now they're like, oh my goodness, if I don't do this, people are going to die. I have to do this. And so really it wasn't even cultural. It wasn't even something socially learned. So we could take the whole social learning aspect, throw it out.
Yeah.
And maybe it's just this idea of, if we don't do this, our species is going to die. And so I'm wondering what aspect of that in communication are we not tapping into enough yet, this idea of evolutionary psychology.
Yeah. That we are, I'm part of a team that's won a grant to look at caring in COVID. So what actually happened when rural, Māori, Pacifica, there were 3 different projects, were isolated in that moment, and what sorts of things were discovered. And you're right, people were afraid to come out after COVID. We had another project with around Kaumatua that involved them meeting others, and they were worried about coming out. Their families are worried about them meeting other people. So I think you're right, and it hasn't been tapped into fully, but there's a lot of, it's coming out now, slowly. I don't know if I'd call it evolutionary psychology, but I'd certainly think it's worth talking about in terms of it's disrupting what we thought was normal.
And I agree, maybe if I may follow, I agree, it may not be evolutionary psychology, but I think that might be the closest literature that we have to that. But it's something different and calm. We haven't really, like, I don't want to call it the communal biology, because that's different. It's not hereditary, but it's something, there's this like, fight or flight, basically, kind of mentality, which is now driving our communication, possibly. Something like that, maybe.
Yeah, and I think I've gone straight to conspiracy theory for some reason. But I think it's because of the fight and flight has created all these other stories around COVID and care, and that are totally off the planet, really.
One of the things I was reflecting on also goes back to what we were talking about in the Methods of the South workshops, Mary, is this idea that the pandemic perhaps also has opened up this space for decolonizing our epistemics in ways that we haven't done historically. As an example, this idea that human beings fundamentally are caring, altruistic, giving, which actually sort of rejects in some ways the foundations of liberal social science, which begin with this game theoretic kinds of assumptions that human beings are competitive and are going to try to optimize what is good for them and are self-seeking. So in that sense, these narratives of care also perhaps offer us another way of thinking of care being ordinary, invisible, but care being in the ordinary, in the everyday, that we are all capable of doing and performing.
Yes, I'm internally optimistic that I think this is a moment of unsettling and change and possibility. And I would like, I'm hearing kindness is a privilege in the back of my mind, but real care is something that people do no matter where they sit in the social stratum. I think it's possible, but can it come through? Can a care philosophy, mentality come through at multiple levels? That's going back to Christine's presentation. Somehow the personal experience of telling the stories to those counsellors somehow made those counsellors see what was really going on. It wasn't just a tick box. It wasn't just okay, this is what the legal thing says. They couldn't hide behind that. So I think if there's some way that the social and economic and political structures can, and they're actually people at the end of it, you know, the people who are enacting those are able to shape them a bit more. I think it's possible that in 5, 10, 20 years, we could be in a different place. As I said, I remain optimistic.
I'm also thinking of a third category of people, like the migrant workers, for instance, who have long distance care to manage, you know, in their countries, which may be several thousand kilometers away. And with COVID are, you know, further disadvantaged because they cannot even the Pacific Islands, for instance, I mean, with their elderly parents there, and they've managed care long distance. And so,
yeah, they managed care because they had work here,
yes,
and they were able to fund and support and then when the jobs were stripped out, they had nothing here and stress about not caring. I agree. And it seems to have taken a long time for those migrant workers to actually get some support and some recognition, and that's at that structural level. Yeah, I agree. Are we allowed to finish early?
I'm sure you
Unless somebody's got a question from somewhere else or a comment.
Let me just check if there are any comments or questions on Facebook.
Not yet.
Not yet, okay.
Angus here. She has a question. No.
Okay,
It's good.
looks good.
Oh, we good? Well, can I thank everybody for listening? And I'm sure that once the camera's off, all the questions will come.
Yeah.
And we'll have a lovely conversation.
Yeah.
And I look forward to that. So thank you very much. Kia koutou katoa.
Thank you. Thank you so much, Mary.